Good afternoon, everyone. Welcome to the fourth session of the National Commission to Address Racism in Nursing's third ECHO series. This series will have a focus on health equity. Whether you've been involved in previous ECHO sessions or are new to this space, we are so excited to be back and hope this interactive learning series is a place for you to find guidance and support. This program is brought to you by the National Commission to Address Racism in Nursing, a multi-organizational collaborative of leading nursing organizations examining the issue of racism within nursing and motivating all nurses to confront systemic racism. This is an 8-part series, and you can earn 1.5 continuing nursing education units for attending today's session. Please stay to the end and complete your evaluation and receive the CNE certificate. Today's topic is, how can we break barriers to health equity, combating stereotypes and bias in healthcare? Before we get started, we have just a few ground rules. Next slide. This is a brave space. Discussing racism and health equity is difficult and uncomfortable, especially for those directly impacted. Discussions such as these can serve as a trigger. We ask that you maintain respect for everyone joining us today. Please stay on mute until it is your time to speak. Listen intently and respond thoughtfully. Be present. Limit background distractions and multitasking. Please take advantage of virtual features via Zoom. We encourage turning your cameras on, using the chat box or the raise hand features to communicate with the group, but please remember to mute your microphone when others are speaking. Please respect participant privacy. Do not disclose names or other sensitive information shared. If you share a scenario involving a patient, please do not use personal information during today's call or any of the ECHO sessions. Feel free to send a direct message to ANA ECHO if you're having technical difficulties during today's call. I am now going to turn the presentation over to Dr. Kellie Bryant.
All right. Thank you for that introduction, and thank you for having me back again for this new ECHO series. So I'm going to share my screen, and thank you everybody for sharing where you're coming from. I see we got people from all over Pennsylvania to Louisiana. So welcome everybody. Can I get a thumbs up? Can everybody see my screen? Yes, thank you, Tracy. Great, great, great. So just to introduce myself briefly, my name is Kellie Bryant, go by the preferred pronouns she and her, and I'm currently Assistant Dean of Clinical Affairs, and I run our beautiful simulation center here at Columbia University School of Nursing. I also serve as a DEI consultant for a wonderful organization called Advancing Health Equity. So that's a little bit about me. So what we're going to cover today, really, we're going to talk about the impact of stereotypes and bias on healthcare outcomes. Then we're going to talk about specific strategies for healthcare professionals to combat bias, discrimination, and when we face stereotypes. How do we deal with that in a healthcare setting? And then lastly, we're going to discuss the role of organizations in promoting a more inclusive and equitable workplace. And then we will go into watching not one, but 2 scenarios. We'll go into breakout rooms, and then the last half hour, we'll come back together and share what we discussed in the breakout rooms. So I'm going to start. We talked about starting with a scenario, or talking about scenarios, and I want to start with a scenario to introduce the topic. And this is a scenario that one of the nurses in one of my classes told me about. She works in an ED, and she had a person come in, a Black male, wearing a hoodie that was found unconscious in his home. They brought the person in, and it did not follow the protocols. There was an assumption based on race, based on what the person was wearing, that the person was experiencing an opioid overdose. They gave a dose of Narcan, naloxone, did not work. The nurse kept on saying, I think we need to order a head CT or some kind of evaluation. Ignored. Ordered a second dose of naloxone. Patient still did not wake up. And the nurse realized that this is not part of the protocol. This is not how we handle when other patients come in. After the third dose of naloxone and realizing that it was not an opioid overdose, they finally set that individual up for that head CT, which was now delayed. And what they found out was that the person had an intracerebral hemorrhage. So when we think about this case, this is not unique, but again, what role did bias, stereotypes play in this person getting delayed treatment? And what was the effects of that delayed treatment, particularly when we're talking about someone who's hemorrhaging, having a hemorrhage in their brain? We know delayed treatment increases the risk of morbidity or mortality. So let's dive a little bit deeper. One thing I want to be clear is that we all have bias, all of it. That's how our brains work. That's how we're built. So I want to start with the definition, and there's many definitions, but implicit bias is the attitude or internalized stereotypes that unconsciously affect our perceptions, our actions, how we behave, and the decisions that we make. These unconscious bias often affect behavior that leads to unequal treatment of people based on race, ethnicity, gender identity, sexual orientation, age, disability, health status, and there's other characteristics. So we use that judgment in the way that we treat other people and we behave. That's when it becomes a problem. And again, this is innate in us. We are confronted with millions and millions of pieces of information every second. We don't have the time to evaluate every piece of information to decide, is this safe? Is this not safe? What do we do with it? So our brain makes these shortcuts. And that's the ability to characterize every person or everything that we encounter as a survival mechanism in order for us to decide quickly whether it's a friendly or it's a threat, whether we're going to run, whether we're going to fight, or we're going to freeze. So unconsciously, we not only learn to associate certain attributes with certain social groupings, such as when we see commercials on cleaning products, most likely we see women in those roles. And then so we associate housework, taking care of the family as a woman's role. But we also develop differential rankings of groups, preference of one group over another. So our biases are shaped by many outside factors, and we're going to talk about some of those factors. Where do these come from? Where do these biases come? All right. And then stereotypes. Stereotype is a standardized mental picture that is held in common by members of a group and that are represented or oversimplified opinions, prejudice attitudes, or uncritical judgment. Okay. And again, we're not born with these stereotypes, these beliefs about individuals. And where do we get them? We get it from our environment, our family. Generation after generation, some of these stereotypes are passed on. We get it from our peers, the groups that we're around. Where else do we get it? Put in the chat. What else influences and promotes stereotypes? Media, yes, exactly. Media. And that means I'm not talking about just social media, but we're talking about television. And let's look at a few examples of that. Again, Mr. Clean. If you look at these commercials about detergent or cleaning products, most of the time they're women in those commercials. I like to use an example, it got cut off, The Big Bang Theory was a show about very smart, nerdy individuals, and the one blonde woman was supposed to be ditzy. And so again, feeding into those stereotypes. When we look at different movies, such as The Godfather, and how they portrayed the mafia. And so we are affected by what's around us. What we see on television. When we look at crime shows and the majority of the people that are arrested are African-American, these actually play a role in creating these stereotypes. I see rap, I see work traditions, workplace itself, absolutely good examples. Trauma also. And then let's talk about media and print. And here's another example. When we look at the newspaper or news articles that are posted online, the way the media portrays things. This is an old example of Katrina. And you can see on the top one, there's an African-American person with some belongings. And in that picture, you can see that they use the word that the person is looting. But yet when it was white individuals, similar picture, they were finding things. Okay, so even the wording that we use can cause unfair and untrue beliefs. So what is the connection? So let's talk about the connection between having these stereotypes and this bias. We know that systemic oppression exists, whether it's homophobia, ageism, ableism, transphobia, racism, sexism, xenophobia, all of these forms of oppression. And what do? They affect people's access to resources, to those social determinants of health. They affect their people that are biased and have stereotypes are not hired for certain jobs. They're not allowed to live in certain areas. So they have limited access to resources. And we know that these resources are important. They do affect our health and our health outcomes. If someone isn't given the same opportunities to have a great, well-paying job, they're subjected to live in neighborhoods, in low socioeconomic neighborhoods. When you live in low socioeconomic neighborhoods, you don't have access to good quality food a lot of times. You don't have access to healthcare facilities and gyms and parks. You tend to live in neighborhoods that are unsafe, so that your health is affected in that way because of safety reasons. Tend to live in areas where you have limited access to good quality healthcare. And then also these areas do not, a lot of times, have the best schools. So when you think about all those factors, those all play a role in affecting someone's health. We can look at zip codes. People that live in affluent zip codes have higher life expectancy. There's a reason for that. The more money you make, the nicer neighborhoods you live in, the more access to better resources that you have. So it is all interrelated. And then how does this show up? How does bias and stereotypes show up in an individual's life? And they show up through microaggressions. And I dread that word because it's not micro when you're the victim of a microaggression, but we're going to use that term. And there's different ways they show up. Microassault, explicit derogation characterized primarily by a verbal or nonverbal attack meant to hurt the intended victim. And that could be name calling, that could be avoidant behavior, or purposeful discriminatory action, not hiring someone, not giving someone the same access. As a nurse, I faced it, coming in a room and I don't want the Black nurse taking care of me, okay? Those are some, one example. Then we have micro invalidations, and that's communications that exclude, negate, nullify the psychological thoughts, feelings, or experiential reality of a person of color. And it doesn't need to be a person of color, a person of certain demographic. For example, you may be telling somebody your personal story about how you've experienced some kind of racism, some kind of ism. And the person that you're telling a story to turns around and says, I think you're overreacting. I think you're just a little sensitive, totally negating your experience. That is an example of a micro invalidation. And then lastly, micro insult. And that's characterized by communications that convey rudeness and insensitivity and demean a person's racial heritage or identity. And some of us may have heard this. You speak well. Your English is great. You're very articulate. You have a pretty face for someone who may be overweight. These are examples where it's kind of like a backhanded comment. They think that they're complimenting you, but in reality, it's actually an insult. And then let's talk about how the stereotypes and the bias and the isms play into its effect on patient outcomes, because it does affect patient care. And these are just a few examples. We live in a society where there is weight bias and discrimination against people of certain sizes. There are studies that show that healthcare providers believe that these individuals have lack self-control, lack willpower, are going to be more non-adherent with treatments and diet recommendations, that they're lazy, and that the reason that it's their fault that they're in this condition. So imagine how that affects the person, the individual. And it shows that people who suffer from this weight bias, it does affect their health. Psychologically, their social and physical health. They suffer from more depression, anxiety, low self-esteem, poor body image, and even substance abuse and suicidality. from this bias and from the experience. Another example, this is from a study that was done in 2014 on opioids. And this goes way back to where we had studies, research where it was a belief that Black people felt pain less. We had thicker skin, less nerve endings. And therefore, that belief from a long time ago still exists, to the fact that Black patients are prescribed much less frequently opioids for pain. And then also, because of homophobia, the LGBT community face multiple barriers when it comes to accessing healthcare and having providers who can provide gender-affirming care, who are culturally sensitive.
Oh, just a second.
In a 2015 US transgender survey revealed that transgender patients face high levels of mistreatment when seeking healthcare. 1/3 of people who completed the survey said they had negative experience when they went to see their healthcare provider. And also nearly a quarter had a hard time getting the care that they need, to the point that because of the discrimination and the bias they face, they would not go to get their preventative treatment, to get their annual exam, because of the fear of being mistreated. And what does that do? When somebody doesn't feel like they can trust the system, that they're not getting that sensitive care, and they delay getting treatment, that can also affect someone's health in a negative way, because they're not getting the cancer screenings that they're supposed to be getting. They're waiting till they're very, very sick until they go to see a healthcare provider. And sometimes that can be too late when we're talking about cancer and other diagnoses. So these are just a few of the health disparities that exist. And a lot of it, again, is due to racism, bias, discrimination against patients. So some of the other effects, it increases misdiagnosis. Because if we're not listening to our patients, if we're categorizing these patients based on our bias and our stereotype, it leads us to not look at them as an individual, but to look at them as a group. That can lead to premature closure of diagnosis. We think that they have this because we're again, putting them into this group. It also leads to decreased quality of care, because again, when we look at the LGBTQ+ community, if we're not being treated in a respectful manner, we're not going to seek care, and that can affect our quality of care. Treatment disparities. We know certain groups of individuals don't receive the same treatments because a provider may think, I'm not going to waste my time, because they're not going to adhere to the treatment plan, or because they assume that someone doesn't have the ability to follow through with a treatment plan. So that can cause disparities. Emotional distress, again, dealing with all this discrimination and bias when we access these healthcare facilities or getting this from our healthcare provider, that can cause emotional stress. And we know what emotional distress can cause. That's also not good for our health. Poor patient-provider relationships, problems with communication, limited access to care, not having providers, again, that can provide that culturally sensitive care. Stigmatization from the time we walk in the door, the looks, being mispronounced, having difficulties just even entering at the reception area. And then the mistrust of the healthcare system, or not trusting that our provider has our best interests. And then that failure to provide that patient-centered care. Again, not having the patient be part of their decision about their care, involving them in the conversation. Should be a mutual collaboration when we go to see our healthcare provider about the treatment and our treatment options, not just one-sided, you need to do this, this, and that. So these are some of the effects of bias and stereotypes when it comes to patient care. And it's not just patient care. Let's talk about in nursing. As nurses working on the floor, racism exists in nursing. And this was a study that was done 2021 from this wonderful organization. And the data was collected. And I don't know if people are surprised by the findings, but 75% of nurses witness racism in the workplace. 63 of the nurses personally experienced it themselves. And of the brave nurses that actually reported it, 57% reported it, but yet 64 of those reports went with no change. Nothing was done. So think about if you're a nurse that's experiencing racism and you're brave enough to report it and nothing's done, are you more likely to report it again? And also think about how that affects your working environment when you're facing this on a regular basis. Makes you not want to go to work. Maybe it makes you think about second guess your profession. And we already have, it's becoming more increasingly difficult to work in our healthcare systems when you add this onto it. And we need nurses. There's a nursing shortage, so we can't afford to lose any nurses, especially over something such as racism. So what do we do about it? Enough about, we covered the problem, we identified its effects, but now what can we do? So some of the things we can do, the first thing is just being aware that, again, we have biases. Do we know our biases? What are we doing about it? There's tests out there. I'm sure everybody's heard of the Harvard Implicit Association test that you can take. And identify, the first step is being aware, self-reflection. And then what we can do about it. And that's a whole talk in itself, but just simple things as look at the group and the crowd that you're around, diversifying your circle, intentionally diversifying your experiences, being around people who don't think like you, diversifying your friend circle, maybe working with that person that you're like, oh, they always have a different way of thinking. I usually stay away from that type, but that can help open your mind and also open you to new experiences. It may change some thoughts. And then personal development. Right now, there's a time where there's a lot of DEI training. There's a lot of implicit bias training. You can take it online. It's in articles. You can have consultants come to your organization. So just being proactive and taking advantage of that. And a lot of that comes from within us. And then having a mindset that we cannot understand or know everything about every culture. We're not going to be able to speak every language. We're not going to be able to understand every religion. But what we can adopt is a mindset of cultural humility. And that means that we know we're never going to understand, but we're open to learning. It's a lifelong learning process. And that we also are looking at things through an equity lens. Whatever we're doing, if we're forming a team, is the team diverse? As a professor, as I'm putting a lecture together, I'm making sure that when I have pictures, that my pictures are diverse, that my case studies are diverse. That when you have committees, again, that you're making sure that you're always looking through that equity lens, even when you're caring for your patients. And then supporting a culture of DEI. Institutions are doing a great job of implementing DEI initiatives, whether that's with recruitment, with promotion, with different programs to address implicit bias. Be at the table when they're creating these programs, making sure that you're going to these programs and supporting them. These are all things that we can do on an individual level. And then another great infographic that came from the Commission on Racism is just knowing where you're at in allyship. So we know that talking about isms, sexism, racism is uncomfortable, but we need to have these conversations and we need to identify where are we when it comes to promoting health equity. Are you in the avoid zone where it's like, I'm uncomfortable addressing racism, I'm afraid to say the wrong thing, that is a real true fear. So I stay neutral, I don't say anything. Or if I witness something, I don't confront it because I don't know what to do. And hopefully as we go down, getting to that last stage where allyship, where we are active, not passively, addressing the isms, racism. That's the goal, but it's a process. Not gonna get there overnight. And then ultimately, being an upstander. An upstander is someone who takes action to prevent or intervene in a situation where there's injustice occurring or there's harm occurring. Meaning you're not just sitting there watching it, but you actually take a step to address it, to stand up for someone. It is very difficult to do, and you have to be brave. So some steps to becoming that upstander is, again, learning, how do you mitigate bias? When you hear someone making a comment that's inappropriate, how do you address it? And again, there's specific techniques, there's action, there's grit, there's open the front door. And on the next slide, we don't have time to go in today, but there are resources that can teach you some of those strategies so that you can use it next time that you face any kind of bias that you want to address. Be empathetic and offer support to someone who may be experiencing it, not telling them that they're overreacting. but letting them know that you're here, you hear them, even though you may not walk in their shoes and may not have that lived experience, that you have empathy. And promoting inclusivity, which we talked about, making sure that we're including everyone and hearing from everybody, not just having them at the table, but hearing from them, giving them a voice, leading by example, confronting bias and discrimination, again, when we confront it, and reporting incidents. A lot of these institutions have reporting mechanisms. So being brave enough to report it so that it can be investigated and hopefully be addressed. And staying informed, just keeping up with what's going on and special initiatives, things in the news, so you can be a part of the positive change. And then joining organizations and committees that are working towards promoting diversity, equity, and inclusion. Again, being there and having a seat and participating in these initiatives. And so I just want to outline, again, we can't go into all the strategies, but here are some of the prior ECHO sessions from the first and second that are wonderful at addressing some of these and going over those techniques. One of them I see Bart is on. Bart, wonderful session. So if you want more information, you want to learn more, again, I would encourage you to go back and watch these sessions that are on YouTube. And lastly, it's not just the individuals. We all need to work on ways to address and promote health equity and address bias and stereotype. So from the organizational level, there's things that can be done. So organizations collecting, analyzing, reporting equity data, whether that's equity demographics about the patients or your staff at the hospital. How diverse is the staff at the hospital? And does that diversity, is it also at the level of the C-suite, at the leadership level? Setting clear equity goals and metrics and analyzing it and looking at it on a regular basis to see, are we meeting those goals? And if not, we might need to change the game plan and do something different. Creating policies for hiring, for reviewing and promotions that recognize DEI initiatives. So giving people credit for the work, especially when it comes to promotion. And education, and for everyone, not just for certain groups. There should be DEI, implicit bias, anything that can help promote health equity kind of training, and giving employees time to go through those trainings and promoting it. And establishing a DEI committee, task force, whatever that is, because it makes sure that it keeps those DEI initiatives at the forefront so it doesn't get forgotten in a year or two. And surveying employees and patients. Are we meeting their needs? All these wonderful interventions that we've implemented, are they working? You got to hear from the stakeholders. And then also having anti-discrimination policies and reporting mechanisms. If somebody's brave enough to report it, as that survey said, 64%, what are we doing about it? What are the mechanisms? Where does it go? And what's being done when those reports come in? Being transparent about when those reports come in and how are they being addressed? So that is just a few. So I'm going to pause there before we go into the case studies. I see the chat was just going. I don't know if we had any questions we need to address.